I'm here with Gaurav Luthra. Gaurav, you presented a really, really interesting case. This is a case of pediatric Lens Coloboma with some degree of ectopia lentis. Can I get you to flesh it out a little bit for me now?
Sure. So this was a young boy with bilateral Lens Coloboma, and 8-year-old boy, and he presented to us with high astigmatism, and when we looked at him more carefully with the dilated pupil, we saw that his lens was almost bisecting the pupillary axis, and his vision was really poor. So we decided, because it was compromising his vision very significantly and was not correctable with refraction, we decided to go ahead with the surgery and try to fix up the lens for him, and I wanted to preserve the bag at all cost.
So how did you approach this case surgically?
So, we had two options to go about. Either we could just go and do a lensectomy and then put in a glued IOL or maybe a scleral fixated IOL. But I like to preserve the bag, and with my long-running course on rings and hooks at ASCRS, we've been trying to highlight how we can use these all these devices. So my friend Ike makes this really nice capsular tension segment, and we decided to use the segment with a CTR in this patient. So both the eyes were fixated with a gap of about 1 month, and we used the Hoffman pocket for doing the fixation. So instead of making the scleral thickness flaps, the partial thickness flaps, we decided to dissect this very elegant technique which Dr. Hoffman has described, where we from the limbus right on the cornea, we dissect a partial thickness plane into the sclera. So this preserves the conjunctiva and all the scleral vessels and doesn't disturb the limbus, and there we anchored the capsular tension segment.
So this is a flap that starts at the limbus and progresses posteriorly.
Absolutely. So it does not, you don't touch the conjunctiva at all, and there's no damage. So tomorrow if you have to do a glaucoma surgery or any other procedure, your sclera is totally preserved, and it nicely covers the suture knot, so you don't have a exposed suture knot as well.
So the common statement is with capsular tension rings that you put them in as late as you can, as soon as you need to. When did you put the ring in this patient?
Right. So here the problem was that this lens was there was a big coloboma as well, and we wanted to distend the bag.
Sure.
So as we started doing, we managed to do the rhexis nicely with the microrhexis forceps, and then as we aspirated the cortex and the bag started to collapse, there was a critical time where I thought that if it collapses anymore, I might just catch it into my aspiration tip, and that's the time when I decided to go with the capsular tension ring in one of the eyes. The other eye, which had a slightly lesser a smaller coloboma, we did not actually put the ring at all. We just used the capsular tension segment and anchored it with a small iris hook till the time that we could complete the surgery. So in the second eye, we could actually manage without putting the capsular tension ring. So it was two different techniques for both the eyes.
Yeah, no, I mean, certainly something very, very challenging. Yeah, no, I'm just picturing it.
But also very thankful procedure, because the child with both eyes operated is now about 6'9" with a very small refractive error and a very nicely centered lens. And I think using the capsular tension segment to actually anchor these lenses is very good. However, you have to be careful as well, because if you feel that your zonules are not great on all sides, you could actually do a 2-point fixation. Otherwise, later on you'll have the lens
insertion,
over a period of time. So you have to judge whether you want to go with this, or if it's a degenerative disease of the zonules like in the Marfan's, you would want to do a bilateral fixation. Otherwise, in a few years you'll have one of the poles giving way as well.
But with the coloboma, that really shouldn't be the case.
It wasn't the case, so we decided to go with only a 1-point fixation for this patient.
Yeah, what a neat case. Even neater that you did it, in that I didn't walk into my office. I'm so happy that you presented this, that you shared this with us, and of course for being so very generous with your time with us today.
Thank you so much. I really enjoy being on your interviews.